Hello everybody, we hope you've had a good week so far. Thank you for joining us tonight. This evening's webinar is on discussing PPE guidance. Joining us on the panel is Will Murphy, who has a special interest in implant and cosmetic dentistry, having been placing implants since 1999. Will plays an active role in postgraduate education and is currently tutoring and lecturing on the implant diploma course in London. And he's held a position of clinical assistant in oral surgery at the QE Hospital. Carl Horton, who has an MSc in both implantology and perio, is an implant co-director, course leader and mentor for VSS, and is an honorary lecturer at UCLan. Faye Griffiths, who is an experienced hygienist, is a tutor for the National Examining Board for Dental Nursing and a presiding examiner. We also have Shelley Coley, who is a competent qualified head dental nurse with further qualifications in radiography, impression taking, and with a keen interest in infection control. She has also completed an infection prevention and control lead, gaining a distinction. We will also be bringing in Fiona Elwood onto the panel later. She is an executive director of the Society of British Dental Nurses, and she has allowed us the pleasure of presenting this evening, to which we thank her for. We hope you find this evening useful. I'd like to now pass you over to Carl Horton.
Thanks, Kate, and thanks everybody for joining us this evening. Really hope you get something out of it. Last time I had to apologise because there was a potential for screams from my child. I do explain it that he's not being throttled, it's just that he tends to play his games, and again I can hear him in the background. Getting a little bit excited, so if you do hear any screams, it's just that, so don't worry, we don't kill the kids too much, just slightly.
Not on a Thursday.
Not on a Thursday, no, he's allowed off on a Thursday. What we're going to do is I'm going to do a little presentation. I'm going to be talking about masks and aerosols, and then Will is going to have a little chat, and then we're going to open up the debate and some of the questions that some of you have kindly sent in. So I really hope you get something out of this. The reason that we sort of brought this together was basically because of all the confusion and all the discord that was happening out there. So it was sort of apparent to all of us that we were sort of a little bit lost. And certainly while I was sort of sitting at home, getting, not bored is the wrong word to use because I've not been bored, I've been very busy, but certainly having some thoughts on what was being put forward and the guidance that was being told, I didn't really understand the differences between some of the PPE. I mean, I knew that we wore masks and I knew there were things called respirators, but I didn't know the difference between these things. So we're going to hopefully clear that up. I certainly didn't quite know as much about aerosols as I know now, and hopefully at the end of that we'll have a bit more information on that. So what I'm going to do is I'm not going to yabber too much because I did that last time, and these poor guys didn't get a chance to get a word in edgeways half the time. So you'll be getting a chance to talk tonight. Kate's on it, and what I'm also going to do is I'm going to look at you guys. I'm not going to do a Sarah Hurley and then kind of just talk like this. So I will try and focus. I do ramble. So let's get to the presentation. So here we are. So I do thank Fiona and the Society of British Dental Nurses for inviting us to do this chat tonight. I'm going to talk now about masks and respirators. So what are sort of masks or masks for really, and primary use is to protect the patients from the wearer. So they're being sort of banded about as we might be ended up wearing them when we go on public transport now, according to some rumors that I've heard. And the idea is they protect our patients so that when we're sneezing and coughing, that's not going to go towards the patient, but it doesn't necessarily protect us. The protection is limited, obviously, because we don't have the seal. And respirators, we have that two-way protection, unless they're valved. So some respirators are valved, and the problem with having a valve respirator is our breath can go back potentially towards the patient depending on where the valve is. And I've put two little eyes there, and the reason I've put two little eyes there is it's quite important that those respirators, they protect our mouth and our nose, but what they're not protecting is our eyes, and that's fairly important when we talk about what we're going to be talking about a little bit later on. So the types of masks that we've got, this little table here sort of shows the differences. So we start off with what we have is a single-use mask, and I've put a little icon there that was in short supply at one point. I think we were all panicking. I don't know why, but people were panicking, and that's how effective they really are. And I've put some little figures on here for us to have a little look at, and it just explains a few things about what everything's all about. So this little single-use mask has what's called a bacterial filtration efficiency, and that's at 3 microns, and that's at about 95%. And it has no particle filtration efficiency in the UK. And then we come down to the surgical mask, and this is the one that sort of is being talked about, and what we're going to sort of see more of use in practices, probably for forever, really. And we've been using these for a very long time. We've probably been using either the type 1s, type 2s, or the type 2Rs. And they've been very common in practice use on a daily basis. And you can see the differences between the type 1, type 2, and then the type 3. And the reason the type 3R is slightly different is it has a little bit of splash resistance to it. So it's been recommended that we often use the type 3R, so that when we get that sort of splatter from the patient when they cough and sneeze on us, and the aerosols that we produce, that we've actually got a little bit more protection. And then as you go down, you can see the differences in what we call the bacterial filtration. So they've got better ability at filtrating that bacteria as it comes through, and it goes up to 98% with these masks. So directly through the masks, that bacteria can't really travel that well through it. And then we've got what we call the particle efficiency. And you can see at 0.1 micron, they're all about 98% apart from the type 1. But there actually isn't an EU requirement for this. This is a US requirement. So the EU doesn't have a requirement for that, but I would imagine that it's similar. It's just not tested, and there's no requirement for those masks to have that. And then we get to the respirators. And this is where there's lots of debate and lots of confusion. Hopefully we're going to clear that up. And this little table sort of shows you that we've got the FFP1s, the FFP2s, and the FFP3s. And what it also shows you is there's 0.3 microns, and we've got that protection factor at 94% with the FFP2. And then we've got the FFP3, which gives us a protection factor of 99%. So that's what we're looking at for our gold standard. Hang on one moment. Are you? I'm going then. All right. Yeah. Well, the usual. Yeah, the usual, please. Yeah. My wife is doing the shop. Off to where are you going? The shop. Sainsbury's. Could you say Waitrose?
Then Marks and Spencer's.
Yeah, okay. Yeah. Usual. Yeah. Right. Thank you. See you in a bit. Rebecca's crisps. Foie gras. Yeah. And living at home. And then
keeping it real, Carl. Keeping it real.
Keeping it real.
And then we've got the N95 and the KN95, and the microns between. I've got no idea where I was. And we've got the differences in the filtration effects on those. And actually today, this afternoon, the Health and Safety Executive released a statement about the KN95s because we've had some reported issues with those. So if you have brought the KN95s, I would suggest you just check on those, because there's been reports that lots of those have not passed the European standards. So there's lots of fraudulent ones around, and lots of them are, lots of fit testers are complaining that they don't fit properly when they're ear looped. But we'll talk more about this, much more about this. And then you've got the N99s and the KN99s, and then the N100s and the KN100s. And they just increase the efficiency of the filtration. So the protection that we have, basically, not letting those particles through. So I'm going to move this little slide, and what this does is this kind of tells us how it all works, certainly with the masks. So there's something called melt blown. And what that essentially is, it's a little polymer that's sort of heated up, and then it's blown over a big cylinder, and it creates a big roll of material, which they then cut up and they then put it in between the layers of masks. So that's how it sort of filters the particles through. And then we've got sort of a little slide here just showing the differences between the sort of the N95 and the FFP2s. And so what we've been sort of told is that we can wear all these different respirators, and we're given all these values. And this is what I found a little bit confusing. I had no idea there was such a thing as an FFP2 before all of this, and an FFP3, certainly an N95 and an N99. But the similarities are they're there with an N95 and an FFP2. you may as well, they've got the same mask, 1% difference. And then you've got the N99 and the FFP3 if you can get hold of them. And why do we look at 3 microns as something that they're testing? When we've got a virus that we're worried about, which sort of is much sort of smaller than 3 microns, why do we look at 3 microns as our sort of testing point? And if the virus is smaller than that, then why aren't we worried that it's going to get through the mask further? So why is this 3 micron sort of business looked at? And the reason that we look at 3 microns and we quote that is because that is the particle size that actually passes through the filter of the mask the most. So if there's anything smaller than that, and I'm not suggesting that the virus actually in its small size on its own, because it needs something to carry it, can float through the air, this little virus on its own, floating through the air, gets through the mask. But actually what we know is that at 0.3 microns, that's the maximum penetration of the mask. So if we think about that, at 0.3 microns, if you're wearing an FFP3, then you're going to filter that particle out at 99%. The good news is anything smaller than that, then it's even better at filtering it through. And that's because these particles, they travel in a random motion. So anything smaller than 0.03 actually gets filtered a lot better. And anything larger than 0.3 actually also gets filtered better. So that's just the actual particle size that gets through the mask the most. So it's the most penetrating particle size. And when we look at the respirators, we're looking for something that can be fluid resistant, ideally. It doesn't matter if it's not fluid resistant, because you can get around that. But if it is fluid resistant, then that just adds a little layer of protection, because those aerosols, when the patient coughs on us, we want a little bit more resistance. So it just offers us a bit more protection, and it makes that just got that bit more resistance, as I mentioned. Do we have to have them fitted and fit tested? Well, the simple answer is yes. If these masks are going to work and you're going to invest in that respirating mask, then you need to invest and have them fit tested. And again, Will's going to talk, they're not meant to be worn all the time. And we can talk about sessional use and reusing of masks as I go later on. I don't want to steal anybody else's thunder. So masks and respirators, what do we know about the evidence? Well, the evidence is weak in terms of protection. We really don't know how sort of suitable these things are between a mask and a respirator. So we sort of talk a lot about the fact that we're using these respirators and that it's going to give us all this protection and it's fantastic and that masks shouldn't be used. But actually the evidence between the two is quite poor. So what's been done and what the evidence is that's out there that does look at this is there are some human studies on this, and it's quite important that we think about this. And what the human studies show is that an N95, if you remember, that's the American respirator, they compared that to a surgical mask and they looked at the difference in people that were wearing them on sort of wards and around patients that had influenza. So I know that that isn't coronavirus, but it's kind of relatable in terms of infectivity. And what they noticed is that they were similar in the protection that they offered for the healthcare workers. So there's a similarity in the N95 respirators and the surgical masks. So what that also tells us is that surgical masks are actually very good at protecting us. So we've been sort of panicked into that we must have a respirator and we need this respirator to be protected. But actually what this is sort of hinting at is that that might not necessarily be the case, and we might not need to be so worried about that. So what they also did, so you could say, well, okay, surgical, I'm not looking at the camera, I'm wondering again, that surgical masks compared to non-surgical masks, did anybody test that? And actually they did. So you can't go around doing this now, it's not really ethical. But what they had is they had retrospective data. So it was an Australian study, and what they looked at is they looked at parents that were involved with individuals that had influenza. I'm less annoyed now, probably still a little bit irritated by some of the things. And the reason I got a little bit angry is the night or the day on the presentation, the Office of the Chief Dental Officer produced a paper, they had a problem with that. Therefore, AGPs create the potential for airborne transmission of infections that may otherwise only be transmissible by the droplet route. This made me really angry. It really annoyed me because I thought that was quite an aggressive statement and it wasn't based on any evidence. And then I started looking around, and I'd looked at all sorts of other papers around the world and all sorts of other things. I've done lots of research on this. So I thought, well, I'll grab that one from the European standards and this one, and this is how they wrote it. Therefore, in the event of widespread community transmission, meaning our sort of COVID level, leading to shortages of PPE, a rational approach would necessitate prioritizing the use of FP2s or FP3 respirators for care activities involving a higher perceived risk of transmission, such as during AGPs or in intensive care. And I thought that was a much more calmer statement. And that statement actually explains that it's a perceived risk, that it's not an evidence-based risk. And it's that perception of risk that we're sort of doing what we're doing at the moment. It's a perception. It's a much gentler approach. I must say that, I won't say well done, but within less than 12 hours, that statement, the first one, was taken off of the SOP from the OCDO, which says a lot to me. So I'm going to talk a little bit about aerosols. I'm going to try and just hopefully clarify a few things, just explain a few things. So we've got differences in the way that aerosols sort of are generated. We've got respiratory aerosols, and we're always emitting respiratory aerosols as long as we're alive. So when we're breathing, we're doing this all the time, and it depends on the individual. So I had a dry mouth the first time that I started doing the webinars, and it's not so dry tonight, obviously because of the gin. And certain people will have a different ability to produce a respiratory aerosol with a different amount of energy and a different amount of aerosol. So everybody's different. So at the moment, my voice is raised a little bit. I'm talking quite loudly. I can hear my son has thankfully gone quiet because I've told him time and time again that I'm going to be doing a webinar to 4,000 or 5,000 people. Thinks I'm famous. And when I'm talking a little bit lighter, then those aerosols are not going to travel as far. So that splatter, that distance, that aerosol, it's a little bit softer, it's a little bit gentler. When I'm coughing, it's going to be ejected, and when I'm sneezing, it's going to be ejected. And this is the sort of the principle behind the social distancing and what we're doing, and why we're sort of potentially wearing masks, is to stop this sort of infective aerosol from coming out. But it's important that we remember this about these respiratory aerosols and what we're doing about it. Are they ever infective? Well, yeah, they can be infective. So we've got evidence that TB is sort of caused by aerosol, and also measles, which is hugely infective. But what do we know about the SARS-CoV-2 virus? Is it primary spread in aerosols? And actually, quite interestingly, there has been no viable virus proved in aerosols, and this is live aerosols in a human study. So they have generated this in a non-human study where they had a drum, and what they were doing was they were rotating this drum and they were creating aerosols. So it was an artificial study. And again, people have latched onto that and they said, well, it is aerosol produced. We don't know. It's too early to tell. But we're not really seeing any evidence to back this up. There were certain aspects in China that came out, but they found out since then, actually, they don't think it was a spread by aerosol. They think that it was people sitting underneath an extractor fan and coughing and sneezing. So what are the modes of infection that we're pretty certain about with SARS-CoV-2? And these are droplets. So as I mentioned earlier, the droplets that are coming out, the formites, so the little particles that sort of land on the door handles and the letters, and contact, so shaking someone's hand or getting our hand and then touching our eye or picking our nose or whatever else it is you do with your fingers. And now we're going to talk a little bit about dental aerosols. So these are the ones that are obviously going to kill all our staff and all our patients, and they're absolutely horrendous things, and we need to bear that in mind. Or are they? And what is an aerosol generated procedure? Well, the definition that's coming through this of an aerosol generated procedure is being more and more defined as we go through things, and it seems to change depending on the SOPs that are being produced. But essentially, it's something that produces sort of droplet vapor. So our ultrasonics, such as the Cavitrons, depending on if you're using that, or the MS, our handpieces, and our 3-in-1 when you're using the air and the water at the same time. So when I say handpiece again, it's when you're getting the air and the water coming from the handpiece, and when it's generating that spray. And what's the evidence that they're such a danger? Well, actually, the evidence doesn't really exist that they are such a danger. The evidence is really, really weak, and it's very, very poor. So there isn't a huge amount of evidence out there that suggests that these dental aerosols are an issue for us. But the reason that we're getting a little bit worried about them is because we get this complexity of the aerosol. So it mixes with saliva and blood, and we get splatter, and we get what we call droplet nuclei, which are those fine particles that we're probably a little bit more worried about, and that's why we're thinking about the respirators to protect us from those. And how can we protect ourselves from this? And that's something like high volume aspiration. Now, all that sort of mixture of the saliva and the blood and the dental aerosol producing that little spray, we can reduce that by using high volume aspiration up to 90 to 98%. Although the studies aren't fantastic on this, they are coming across more and more. And this is one of the studies that's not been published yet, but it shows the efficiency of having high volume aspiration next to this aerosol that's being generated. The splatter, well, if you're wearing a mask or a visor and a visor, well, then that's going to protect you from the splatter. And the droplet nuclei, well, that's the little sprays. They're going to be taken up by the high volume aspiration. We can't stop that mixing with saliva and blood. That's naturally from what we're going to do, depending on the procedure that we're going to be creating. So I've just added a little bit. And I must say, I must thank Ross Hobson. He actually said, yes, you can use this little video tonight. So I said, great, cheers, Ross. I've just put that up because I think it's quite important that you get to kind of view this and see how much by having that high volume aspiration there that you can, I'm just going to top up the alcohol level, that you can see how much that takes the spray up. And I think it's quite effective in showing how efficient that is. So what he did is he put a little dye into the dental unit waterline and then sprayed it and took this little video. There are others on YouTube that show how efficient this is. So this sort of dental spray that we're using, don't forget we're using these respirators to protect us from this. 98% of that is going up the high volume suction in theory. So how bad are these sort of aerosol generated procedures? And this is the question hopefully we'll sort of run through a little bit. And when it comes to sort of the perceived risks, well, we're looking at sort of mitigating those as a whole. So what we're doing with the SOPs that are coming out is we're trying to triage things. We're trying to bring things down as safe as we possibly can. So we're triaging our patients. So we're asking those that we think are infected and infective to stay away from the practice. We base it on the alert level or the R number. So if the R number is sort of below 1, then we know that the infectivity of the disease is dropping. It's not going up exponentially, or it's not increasing. We can offer a sort of a pre-treatment, such as a mouthwash, and there is sort of lots of different things being said about this. Chlorhexidine is very good at being antibacterial, but not very good at being virucidal. So there's a mention of asking patients, and I've seen some guidance saying that they actually rinse as they walk into the practice before they even get into the surgery with hydrogen peroxide rinses or povidone iodine. The research that's come on from that, and again, it's not hugely well evidence-based, is not fantastic, because what it's actually suggesting is that the patient washes away the efficacy of this mouthwash within about 30 seconds, and it's been replaced by their own saliva. So unless you're getting your patients to rinse every 30 seconds or so, it might not be that effective. But I don't see any harm in suggesting it. The high volume aspiration, as I've mentioned, really efficient at reducing the dental aerosol that's being generated. The rubber dam, 98% effective. Not very useful when you're trying to use an ultrasonic on a patient. A little bit difficult. The ventilation of the room, that's been sort of talked about, and there's been all sorts of ways of that I've seen about actually working out how to ventilate the room, but opening a window is a pretty good idea. Whether you keep the door open or not, you could argue about the aerosol sort of going out the door, but it's something that's up for debate, and evidence on that is very poor. You can get experts on helping you out and helping you to understand how much air is being moved in and out of a room. So the idea of the ventilated room is that when you've done an aerosol generated procedure, the aerosol that's sort of floating about with all those nasty, horrible, infective bugs that we've been working with for years and years, and that have obviously killed off most of the dental profession, are then out of the room, and then we've got a total fresh air. So there are variations on how long you can, what we call fallow time in the room. Air conditioning, well, Public Health England have suggested that that's actually okay. So we were told that maybe it's not, and then we're being told it can be. But I would suggest that it's non-recirculating. And then air purifiers, there's lots of air purifiers being mentioned about HEPA filters. These might drag the air through, and then they might filter the air as they go through. Again, because this is all new, the evidence behind these it's not fantastic, but it's there. It might help, and so I've got no issues with anything that might help and just reassure us a little bit that things are good.
Carl, we're hitting 7:30 now.
Oh God, have I been going on for so long? I do apologise. So I'm going to speed up. So basically, there's no evidence that the SARS-CoV-2 virus is in aerosols. So that's good. That's sort of a positive for us. It should hopefully just reassure us a little bit that what's happening when we do produce these aerosols is it's not that infective. It's not that much of a worry. Universal precautions, well, they were working pretty much before the pandemic. We haven't seen any evidence worldwide of dental workers showing increase in COVID of themselves or their patients. There's just nothing out there that's suggesting that. And we're quite late coming back to the party and opening up our dental practice, unbelievably late. Yet around the rest of the world, we're not seeing these hotspots, and they're not all using, and it is said that they're all using filters. They're not all using filters. So some of them are using surgical masks and visors, and they're using aerosol generated procedures, and we're not seeing hotspots in those workers either. So we're just not seeing that. And you'd think that if it was an issue that we would be seeing it. So the message to everybody that's listening and to all the public, I think, is that we're safe. We're a safe place to visit. We are very good at what we do. We've always been good with what we do. We've dealt with infective patients forever. We've always done that from when we were students to where we are now. So I'm going to just briefly go over a couple of SOPs and so that you understand them really clearly. What I did is I had a look at a recent one. So if you have a brief look through that explains it all. They obviously do discuss type 2 and type 2R masks there for surgical procedures. So, it's all very, very clear, isn't it? All the SOPs are really clear for us, all of us. And when this was all coming through, I just had the wonderful idea that for those of you that remember, it's top of the socks. So we're being inundated with these, and got number 10, my dentist. Got number 9, number 8, the BDA, the officer, the chief dental officer, and then they did a quick remix. And then we've got Portman, got British Society for Odontology, British Endodontic Society, we've got the FTDP, but most of all, what you need to do is do it yourself. So I really do appreciate you listening to me rabble on. I'm going to stop sharing my screen if it'll let me, and I'll pass you back over.
Thank you. Oh, that's great. Thank you very much. Before I pass you over to Will, I just want to reassure all the people that are listening. I know quite a few of you have had some problems with connection and missing a large chunk of what's already been discussed. But let me reassure you, there will be a copy made available of the webinar for you all after this, so no problem. Will, if we can just gently pass over to you, please you may indulge us with some fit testing information.
Yeah, thanks very much, Carl. That was great. Much calmer than last time. I was expecting to be the Susanna Reid to your Piers Morgan, but you were...
Well, you're the eye candy, mate. You're the eye candy.
So we need to stoke up some more anger, I think, next time. So I think the key message that you came out with, and if anybody's used to watch Dad's Army, if they're as old as me, don't panic, I think, is the message, really. When we get onto this subject, and in dentistry in a whole, I think in the last few years, we've all got used to jumping through hoops. So we've had CQC, HTMO, all this sort of stuff. We're very used to rules and regulations. And so I think the way to look at it is that all this stuff is just another little bolt on to something that we probably do pretty well already. Now, first of all, we get another hoop to jump through, which is talking about masks and things like that. And then the other thing that obviously then starts to complicate the issue or cause more problems, perhaps for all of us, is that these masks have to be fit tested. Otherwise, you leave yourself open to having a mask that may not fit properly, and then there's no point having it at all, really. So I've been lucky enough to gain a new qualification, which I have here. Forget any fellowships or memberships. This is the hot property. This is the one that you want to have. So this this tells you that I am able to fit masks for you. So what does that involve? Basically, one of the things I wanted to sort of bring up to people is that the mask fitting test can take a little bit of time. Okay, so if you are having all your staff done, which I presume everybody will be, you're going to need to have plenty of time booked off for this. You're really looking probably at about 15-20 minutes plus when you're testing people. And the point I like to make out as well is that it's an all or nothing test. You either pass it or you fail. So you've probably seen pictures of people with the big hoods on. So this is all part of the procedure. You're wearing that, and then you're being subjected to, usually it's a bitter solution called Bitrex, which will be squirted into your mask. Initially, it's done just to sort of check that you can actually taste it. You'll be there with your mouth open, it'll be sprayed at you, and there'll be a number of sprays which are going to come at you through one of these things. Okay. Yeah, it's a little bit like a little pump that asthmatics may use. Okay, a little sort of volumizer like that. Once you sort of work out how sensitive you are to this bitter solution, then you're going to don your mask. Okay, so there we go. There's the typical sort of mask you have. I'll talk a little bit about fitting of these later. So you will be sort of guided on how to fit it properly, but you'll be expected to be able to fit that yourself without anybody sort of helping you. And then you're going to go through a series of exercises where every 30 seconds, the old bitter solution is going to be squirted through a little hole at you. Now you're going to start off with normal breathing, then you move into deep breathing for a minute, then turning your head side to side, moving your head up and down, talking, bending over, normal breathing. And like I said, it's a pass or fail. Other things that will sort of help you, save you time as well, will be try not to smoke, eat, drink for a good 15-20 minutes beforehand, okay, because this can affect your taste sensors. The other thing for the gentleman is that you're going to have to do a little bit of male grooming and either completely clean shave or get yourself a nice goatee beard, because these masks really do require sort of nice skin fit, okay? Other things that people are getting confused on, and I think we touched on it before, are whether they're going to be likely to be sort of ear loop masks or whether they're going to go around the head. Now these FP2 and FP3 masks, you know, these ones really go around the head, okay? So again, you'll be expected to know how to hold it in the right way. Usually you're lifting the bottom one over to the back of the neck and the top one just below the crown of the head. So these are the sorts of things that you can expect. The problem being, of course, is, like everybody knows, is that you've got to get hold of a kit, or you've got to find somebody who's got a kit. And if you do get a kit, you'll become very popular with your fellow dental professionals, because everybody now is just about, I get the feeling, able to start getting their masks in. But then, of course, they want to have their masks fitted and tested and make sure their staff have been correctly fitted and tested as well. So this is where the problem lies. Now I've got a full kit, which I've ordered, but then the suppliers are saying, you know, it's still hot footing its way over from China. And as a result, I'm now trying to source individual items like this, hoods and Bitrex solution. And you can spend a good couple of days on the phone talking to various builders, merchants who just go, you're a dentist. You're the 10th dentist we've had already today. So these are the real problems that you're going to get when you're trying to get these mask testing kits. So that's really the testing procedure. I don't know if anybody's got any questions on that.
Can you use links?
Can you use links? Only denim or Old Spice.
Yeah, okay.
It's very specific.
Yeah.
Will, what about, a question has come through. I mean, what about, it could be for men, clearly, but what about the use of makeup? Is that going to fit much of the fit of the mask?
It depends how many layers you've got on, you know. I tend to keep it fairly light, so it doesn't affect things. Carl usually has about 7 or 8 layers. So
I had to take the trowel round when we were.
Exactly.
I reckon I've got the shine off of the yeah.
I'll be honest. I couldn't tell you one way or the other. I think common sense tells me that the less you have on your face and the closer fit the mask is going to be.
Yeah. Okay.
Yeah, I mean, I suppose maybe the question would be, if you're going for a fit test and you're then going to put makeup on and you don't wear it at your fit test, then you might not get the seal. So as you go for your fit test, that's how you want to be when you turn up to wear the masks as routine.
I think it is important. So if you wear glasses, wear your glasses. You might want to bring your loupes. So you want to try and recreate how you're going to be when you have your mask on, so that it's more effective and it's going to be an accurate representation of how you are at work.
Yeah.
Okay, great. Are we okay for a few questions, guys?
Please, yeah.
Far away.
Some of the questions that have come through, they've been pretty similar, so we've tried to condense some of them. Does anybody want to answer PPE requirements for AGP and non-AGP procedures? I know we've touched upon it already. Does anybody want to pick that up?
I mean, I'll give you my take on it. Like Carl says, this is all DIY. I think for me personally, so I'm going to allow my staff to decide what mask they want to wear and when. So if they're feeling uncomfortable in any situation, they can put one of the FP2 or FP3 masks on. You know, I don't have a problem with that. For me personally, I think if I'm seeing somebody to put a temporary dressing in, you know, any sort of non-AGP procedure, I'm quite happy with a normal surgical mask and a bib. I'm not going to gown up because I don't believe that with all the mitigation that we're going to be putting in place anyway, our patients are going to be particularly effective if we're just doing maybe a routine examination or putting a temporary dressing in or fitting a denture. Now that's my opinion. I don't know how you feel about that, Carl.
Ooh.
Contentious.
No, I think you're you see, the issue that I've probably got is the issue with AGP as a problem. And I think what's happened is I get a little bit more political than Will. I think Will's answer is very sensible and measured. And I think that's correct. And I think that's the correct way to be. My problem is with the direction that we're going down and sort of being indicated that an aerosol generated procedure is a terrible thing to be performing on these patients. And it's really, really effective, when the big thing is the splatter and what's coming off the patients. Don't forget, these patients, when we're not doing these aerosol generated procedures, are still breathing and they could cough and splutter. So you've got to think about reducing that. And then we've got sort of mixed messages from some of the SOPs that are coming out. So they're saying that you can polish teeth and that's not regarded as an aerosol generated procedure. So I think that if you had somebody, like we said, Will, that thought, well, actually, I don't feel comfortable, you know, with this. I don't like the look of her. I want a respirator on. And I think that's absolutely fair. I think that's, you know, it's how you feel and how the individuals feel. What I don't like that's being bandied around is that this is a must, because it shouldn't be a must. We are all capable. And I think one of the things, you're quite right, I didn't get as sort of animated as I did last time, is that we've got, yeah, I'm getting there. We've got these people that we're looking up to that are regulators, and we're asking them for this guidance as a whole. And they are, we want them to tell us how to do things, and we want this black and white, this is what you need to do, this is what you don't need to do. And we want that, when we get that, we want them to base it on the evidence that exists. And so we had things like HTML 105, which a lot of it was not evidence-based. So if you remember, you could put your instruments in a bag, and then all those nasty bacteria could jump in that bag after a very short time in England. and then you had to re-sterilize it again. But for some reason, the bacteria in Scotland aren't quite as efficient. The Scottish obviously are more hardy, and you didn't need to do that. You could leave it for, I think, these 6 or 12 months. I can't quite remember. So they've obviously got different bacteria as you go over Hadrian's Wall. And all of a sudden then, those sort of poor bacteria migrated all the way down to England, and they weren't able to penetrate those bags anymore. And it's that kind of sort of situation that we find ourselves in again, almost. So we have to kind of be the grown-ups. And what I said, I think my analogy was, it's like the parents are sat upstairs with a glass of red wine and a gin, drinking away, and we're going, we're shouting, tell us what to do. And they're going, shut up and be quiet. And that's it. And not giving us any guidance. So we're kind of running around feral. And we're getting this kind of guidance, thinking, well, I don't get it. I don't understand. Why have I got to buy an FP2, an FP3? Which one is it? Do I have to get fit tested? Don't I have to get fit tested? How long do I have to leave the room for? If I do an AGP, how can I do an AGP and I can polish some teeth, and yet I can sit there and do a BP and the patient can cough on me? And it comes down to the triage. And I think that's the thing. The other good thing that the evidence is coming out is the evidence is kind of sort of suggesting that patients that aren't showing symptoms are very poor at actually being infective. So they're not shedding as much virus. And I didn't want to get too involved in this, but I was chatting to an immunologist last night, and I was asking him these questions just to confirm on that. And so we're seeing some of the evidence that these patients that are generally going to be walking through our door are probably not going to be infective as much as we think they are. They're always infective. They're always, sorry if there's any patients listening. Well, we all go to the dentist. We're all dirty. We all spread our germs and our diseases. And it's mitigating that risk. And everything that we do, including the mouthwashes, which the evidence isn't great about, and including the PPE and the masks and everything we've done prior to this has been pretty decent. And that hasn't changed. And
I suspect that, and again, based on no evidence, but I wouldn't be surprised, if it does transpire that the coronavirus was in the country a lot earlier than we thought. And I suspect it probably was, we were probably wading through it in our surgeries from December through to March. So, again, this will all transpire. But also, I think we have to accept, don't we, that we've got the profession is very disjointed in the UK. Because you've got CDOs here, there, and everywhere, and even one popped up for London. I saw as well. Who knew? Who was telling a completely different message from CDO England. So I think that's why I don't get angry anymore. My anger's all gone. It's all ebbed away now. So for me, we've just got to get on with it, haven't we? We're not going to get any leadership, so don't sit around expecting any. I'm turning it to you now. I'm having a rant. So
I've just got to quickly say, Shona, I'm sorry if I gave the perception that you didn't turn your instruments over in Scotland. That's not what I said. So if you misheard me, maybe I did. I'll have to watch the replay. But what I was going back to is that there was a difference between the turnaround times between Scotland and England, and we had to turn our instruments around quicker than you did in Scotland. That's what I was alluding to, the differences in that. That's why I was making light of something that.
Well, how long you could leave things in a pouch in a drawer for? It was 2 minutes, and then it turned into 6 months or a year or something, didn't it?
Yeah.
All the girls were changing all the dates on the little stamp thing that they
Shelley, Faye, I mean, I know that you two both work in great teams. Faye, yourself, I know you've got a few teams. Shelley, I know your team, you've got a great team. What would you say, Shelley, I know your practice is open, but what would you both say are your team's biggest concerns with PPE?
I think people are losing their confidence because there's so much vagueness and so much mixed messages, and I think people are just stuck like rabbits in the headlights, really, and are looking to us to give them some bit of guidance. Trying to find PPE, because a lot of practices have actually given it away to the NHS medical teams as well. So trying to replace that is going to be a bit of a problem as well. But I would sit down and talk about it, with the other members of your staff, and have your own individual roadmap, because one practice is going to be slightly different to another one, because the logistics of that is very different. The whole geographic location is different. You know, you might have 6 surgeries, you might have 2 surgeries. How are you going to deal with everything? It needs talking.
Yeah. Shelley, if your team sort of taking it well this week, coming back, would you say? Are they going through the processes?
Yeah, I mean, we haven't started doing any AGPs yet because we're not due to have our fit testing done until next week, once Jag's been to London and trained how to do it.
We'll send Will down.
Yeah, Will can always pop round. And, yeah.
Not another one, another practice. We'll be giving up dentistry this way.
We've been triaging and seeing non-AGPs. So we did a lot of role play beforehand, went through different scenarios. It just goes against the grain of everything that you've been taught as a dental nurse in regards to no PPE outside of the surgery. And then these fallow times where we're just supposed to follow the patient out and leave the surgery for 20 minutes, that's really got us, we're sort of itching to get in there and clean. But I think on the whole, I know a lot of the girls I work with feel better for getting back to it, and we can see how things are going to be.
Yeah.
And just taking it day by day and just talking it through and making sure, I've spoken to them all this morning and said, if there's anything you feel uncomfortable about, you need to tell the dentist that you're in with that day, or come to me or practice manager, and just, we've got to just all stay in contact and just
great.
Talk. Yeah,
absolutely. What another question that's coming through is the surgery flow for donning and doffing PPE. If any one of you want to pick that up.
I can. I mean, this week we're a 6 surgery practice, and originally the principal dentist, wanted to use the 2 surgeries that we have downstairs as the surgeries that we would see patients in. Therefore, it would mean, because we've only got 2 surgeries downstairs, going upstairs to the next floor to don and doff PPE. So me and the practice manager sort of put our foot down a bit and said, well, no, we think it would be better if we have the 1 surgery downstairs for patients, and then the 2nd downstairs surgery for donning and doffing. And then upstairs, you have another surgery to see patients in and another surgery upstairs to don and doff, rather than sort of traipsing all through the practice, fully ground up. It just, yeah,
thank you, Shelley.
Okay.
Fallow time, Shelley, I know you've just touched upon it, and I mean, a question, it's echoing really. I think we had the same last week, guys, but what's the required fallow time post AGP procedures?
Well, I think 60 minutes has become the magic number, hasn't it, since the FGDP brought out their guidelines. But of course, it's 60 minutes from when. When does it start? So everybody's going to have their stop clocks ready, and it's going to be, aerosol ceased now, hit the clock, and then, so we can, get you 60 minutes that way, really, or is somebody going to tell us that it's 60 minutes from when the patient leaves the surgery? I don't know if you've got an opinion on this, Carl. I reckon.
Oh, yeah. yeah, I have.
Let's have it.
Yeah, well, what are we doing with what's happening during those 60 minutes? And I think that's the question that you've got to ask. So someone's plucked a magic number out of nowhere, really. Again, the evidence, it doesn't exist. And so this 60 minutes downtime, the idea of that is to allow those sort of little sort of droplets to land that are floating around in random motion to land on the floor, and then we can sort of mop the floor and not worry about them. But it depends on so many factors. It depends on the airflow through the room. It depends on the size of the room. It depends on the amount of time that you were doing the procedure. So I think that it really should be based on an individual practice and how they feel and how they feel comfortable about it. So I think if you were in a pokey downstairs basement room with no aircon and no sort of turnaround of air to a huge amount of degree, then that might make you think, well, you know, maybe I want to leave it for 60 minutes. If you're in an upstairs surgery with door open, window open, and you've got a very big airflow going through there, there's a big hurricane whistling, then it might make you think, well, actually, I can adapt this and bring the downtime down by a certain amount of time. And there's studies on this. There's quite a few studies on this, and they're quite interesting studies. I don't want to get too involved in that, but I think it has to be sort of discussed within the practice and how the staff sort of feel comfortable with this. And I don't know whether I had a dream about this. That's how sad I must be at the moment, reading all about these things. But I think it has to be sort of based on a comfortable team discussion, and to remember that some of these things that are being banded out are guidance, and there's not a huge amount of evidence base on this. And that's what we probably should be looking at, which is probably a cop-out for the answer, isn't it, on my part? But I'm trying to sort of explain that if you're able to do an aerosol generated procedure, and that 98% of that aerosol has been taken up to the aspirator, and you're left with 2%, and that 2% is supposedly going to be floating around that room for an hour, and your patients have been triaged, so you've got pretty much non-infected patients. I mean, we've been working with aerosols forever, and we don't show any more incidents of, and this is what I was sort of relating it back to, incidents of TB or measles and things like that within the dental surgery. But I think we've got to be careful because of the times that we're in. So I think that to go against the guidance wouldn't be correct, but I think you need to adapt the guidance to your own practice and your practice staff, and I think that's the important thing. And if we're looking for definitive answers, that's where we're going to struggle, because this is new and we're in a new situation. So there isn't any black and white, and there probably shouldn't be, because each practice is different. But there are guidelines, and I think it's to remember that they are guidelines that we can all work with and make ourselves feel safer. And I think that's the important thing, that we all feel safe. And I think if the team members don't feel safe, well, then that's a worry, isn't it?
I think as healthcare professionals, you know, we're always acutely aware that we've got a duty of care to our patients and to our staff and ourselves, you know, and that I think that always is number one. You know, I think we're a very good profession for that, whether there is, you know, partly fear of litigation and things like that. I think we are generally, you know, very good at this sort of thing already. So we're pretty good at risk assessments. We're pretty good at our infection control. So we're just the way to look at it, I think, like Shelley is saying, you know, is to not get too panicky about it. Have a run through, make sure everybody's sort of comfortable with the procedures that they're doing. You know, don't get too overawed by the whole thing, and just follow through your basic procedures that you do already. I think the likelihood, I think, again, with his crystal ball, is that we're all going to start off ticking the boxes of the 60 minutes and following the guidelines and using those as a framework. I think everybody's probably acutely aware that these things, these SOPs, are going to be living documents, aren't they? So things, I suspect, will be modified. If we go through a period of time, perhaps, where we're not seeing any spike or anything like that, or unusual transmission rates from dental practice, then I suspect we should probably then see sort of modifications of this.
Okay, thank you, Will. Will, we've had a question come through. Do the masks need to be retest fitted over a period of time?
I don't believe so, because I think the mask fit test, you know, is a test that you will have for a specific brand of mask. Okay, so if you are using this one, this is a 3M, then, you know, you have to assume that you then know how to fit this effectively. If you suddenly get a new batch of masks come into your practice, then really you should be having a new fit test for that mask. So on the paperwork that you should be given, okay, it will ask you to put in the actual make of the mask. So you're getting your mask fit for a given type or brand of mask, and I think that's quite important. Okay, so if you are buying lots of different brands of mask, maybe it's worth just getting those tested, or try and find the one that you're comfortable with and you're confident is the one that's going to fit you. Like I said before, these are often a pretty similar shape. So, you know, somebody with a nice round head like me, they fit very snugly, okay? But you're getting little nurses or little smaller members of staff with different sized faces, and a lot of people find it hard to get a mask to actually fit and pass the test. And like I said, it's a pass or a fail. If you fail, you have to take time out, you know, rinse your mouth out, try and get rid of this taste, which will stick with you for a while, and then repeat the test. So there is a lot of time consuming process to go along with this. And also, you know, if we are showing a duty of care to our staff members, you know, I think we do need to make sure that for each new brand that they are fitted correctly.
Thank you, Will. Will they be required to wear fluid resistant masks over FFP3s and FFP2s? Carl?
It would depend, really. The requirement, no. I'm just going to clarify something because I've seen it. I'm reading through the questions as well. So, do you need a fit test for an FFP2 and an FFP3? Yes. They all need to be fit tested. Otherwise, they're not producing the efficiency that you need. Sorry, what was the question?
Will they be required to wear fluid resistant masks over FFP2?
Over the top of the FFP3?
Yes.
Well, it depends on how you feel about things. Required, no. Would you want to? That would depend on what you're trying to achieve. Now, if you remember, I put two lines up at the beginning of the presentation, and I did that for a particular reason, and I think I might have skipped over it, or some of you may have missed it. So if you're wearing a mask over your respirator, then you're probably wearing it because you've got a valve on it. So as you're expiring, your air is going out of that, and you don't want that to go into the patient's mouth. In terms of what the respirator is actually doing, as Will was talking about, it creates a seal, so you're pretty much protected. If you're thinking about reusing it again and you want to prevent it getting splashed on, then your mask, yeah, that's going to be perfect. So it's going to help probably increase the amount of time or the reusability in theory of the mask. And Will's probably more of an expert on that than I am.
Absolute world-leading expert on these things. I think it goes down to a point of economics, Carl. Apparently, dentists can be mean and tight-fisted, and you know, like to get the most for their money. So, by having another mask over the top, you know, potentially you're trying to protect that one from getting splashed. Because if it gets splashed, then that's it. You know. So again, there are no real hard and fast guidelines, but I think people are generally using one mask per session. Okay, so if that gets splashed and then you are planning on seeing another patient afterwards, then it goes in the bin.
Yeah, he sums it up much quicker than I can. Yeah, just Carl, just stop rambling, just get to the point. Just tell us like it is.
Hand scaling. Someone's mentioning hand scaling. It's just got hand scaling. Can we do hand scaling? I'm imagining they're meaning the PPE surrounding it, Faye.
The BSP, the British Society of Periodontology, just issued the other night. Where are we? It's Thursday, so it could have been Monday or Tuesday night. They issued a standard operating procedure checklist and put the risks into 1, 2, and 3. It's worth having a look at that because they were saying that the hand scaling, you can have level 2 protection just using normal surgical hand mask and a visor as well. But they were really advocating the use of a dental nurse using 2 aspirators, one, a saliva ejector at the back of the throat, so that the fluid doesn't pool in the throat so much, and also high volume aspirators. So I would always ask my nurse to aspirate even when doing hand scaling as well. So it's worth looking at that. Go on the BSP website and have a look at their newest information for that.
Thank you, Faye. We also had a question come through regarding PPE and CPR and what to expect when they go back to work. Anybody want to pick that one up?
As in, what do you do when a patient has a CPR event?
That's all that's come through, but I'd imagine so.
Or a member of staff.
Yes.
A CPR event. Do you want me to answer it, or do you want somebody else to answer it?
I would
can answer it because I know what the guidance is.
I think you're all going to say pretty much the same thing, if I'm honest. So,
well, when you look at the guidance that's been issued, the guidance, all of a sudden, it doesn't become an AGP issue. So all of a sudden, if a patient had, and probably quite rightly so, you know, in my opinion, then that patient is then a priority for you to resuscitate, however that may be. So the idea of, you know, waiting for the ambulance to turn up and everything like that, no, that just goes out the window. I mean, the triaging, and this comes back to the triaging, what we're doing. So we're triaging our patients prior to them coming into the surgery. That's I mean, you can do the temperature checks if you want to do those, but you're asking the questions, and you're getting the low risk patients through the door first. So if the patient does have a cardiac arrest, then you treat the patient as if they didn't have COVID. And I think, based on the fact that that goes with what the health and safety executive have suggested, that and innately it's kind of how I'd feel. Really, I'd want to probably save the patient's life. The difference is, I guess, for me, and so I've had it. I went for my tests on Wednesday at the dental hospital. Very interesting, but yeah, I hate giving blood. I hate needles. Sweaty palms, everything like that. But that was great. That was so
karma.
Yeah.
Yeah.
Do you mind if I talk a little bit about the stealth? Well, they're not just stealth masks, but the masks that are non-disposable. Will, do you want to talk much about those? Do you know much about the?
Well, only that I've ordered some that haven't arrived. So
yeah, maybe
it's another scam I've fallen into. But I think the big question that people have about them, and I know friends of mine who've got them and have passed their fit test quite easily. I think the big talk is about cleaning them, isn't it? And again, clearly, like everything else, there's no guidelines, but common sense is going to tell you you're going to clean it like any other dental surface, really, I think.
Yeah, I mean, that is the interesting one, isn't it? Is how do you handle them? You know,
how do you doff them after?
Yeah, how do you? And I think that the guidance doesn't really exist on that. So, can you use them? Yes. Are they going to be efficient? Yes. But how you manage them, I think that comes down to the you deciding on a protocol within your practice, writing it out, and kind of understanding. You know, we all do it. We all do it when we're dealing with patients all the time. So it's understanding how you deal with that reusable respirator, and understanding, you know, and managing that risk within your own practice. And I think that's one good thing that we've been allowed to do, probably because they didn't think anybody would bother spending the money on them. Maybe, I don't know. Call me a cynic. But yeah, they certainly are. Their filtration levels, I mean, you can get them that are much higher than the FFP2 masks, and they're probably more available, I would have thought, unless now they've watched our webinars and they've gone out and brought them all up.
So yeah, sell at a higher price.
Yeah, quite possibly. Yeah.
Fantastic. Is there anything else from the panel that they want to add before we close up?
I think so. I'm out of absinthe, so.
Carl?
Oh, I could go on.
Oh, okay.
Yeah, don't encourage him. My tea's ready.
These people, they've got a life. I've not got a life. I can talk about this forever. I mean, I can see questions coming up. I could go on, and I know that you guys. I mean,
Yes, it should.
I think
there will be a chance to listen to our wisdom again, though, won't there? Next week.
Yeah, I think that we probably need. We've been going for over an hour, so there are lots and lots of questions, which hopefully we've answered most of them. Some of them we haven't had a chance to get through, and we can do. I'd be happy to run another one of these. I know that Will and I and Kate will be doing some little sessions going forward, and obviously Shelley and Faye, when they're available. They didn't know about this, but they're more than welcome to join in. We'll have other people joining us as well, so we'll do these little snapshot events of how wonderful our days have been, and hopefully just help people going along. But I do think, Kate, we're going to be inviting a special guest to come and have a chat.
Yes.
Have you done that?
I'm just about to.
Can I just quickly add then, because I can see it coming up over and over again. The fallow time for the non-AGP, my understanding is it's 20 minutes. We've been leaving our surgery for 20 minutes if we've just done
It depends on whose guidance you're going to follow. So the evidence doesn't exist.
Yeah.
And I think that you need to have a conversation with the practice team and then decide on what you're comfortable with as your fallow time. So there are variations on this, and the variations on this tend to look at the aerosol generating procedures being the key to having that fallow time. Now, did you mention aerosol generating procedure there, Shelley, or did you say that it was a non-aerosol generating?
That was non-aerosol. So for an AGP, 1 hour. For non-AGP, 20 minutes.
Okay, then you've probably just got, I mean, if you're comfortable with 20 minutes, and that's what you've decided as a team, then that shouldn't be an issue. But you're asked, what are you doing within that fallow time? What is it that you're doing to allow for what? If there were no aerosol generated procedures, what is happening in are you going for a coffee, a fag?
Coffee and a slice of cake.
Yeah.
Always.
Yeah.
A little coffee shop down the road, maybe.
No, that's still closed. So it's just Nescafe Gold in the staff room.
Yeah.
I suppose it's just a bit. I don't know, really. I mean, I think, like you've said, even just talking, we're releasing aerosols, and so the 20 minutes was a time for us to just come out, doff all our stuff. Whoever's been in then goes and sits in another surgery, types up their notes, the surgery's left, and then we go back in after 20 minutes.
I think it's easy to extrapolate, isn't it? Randomly, without any science, a new rule or a new procedure. Why 20 minutes in dental surgery when now we're all sort of barging around supermarkets?
Yeah.
Like foie gras in Carl's case from Wake. Was it caviar?
Kate, someone was asking about the reduction in suction with using the saliva ejector and the high volume aspirator. I know that a certain corporate that I work with are sending all their engineers out to check that the suction units are able to cope with that. So it might mean you're talking to the practice manager to see whether they can arrange something like that. I don't know if that helps.
No, thank you, Faye. I've sent a link out to Fiona. Fiona, if you have a look in your emails, there should be a link just for you to hop on and join us.
Brilliant. I mean, if we'll give Fiona just a few minutes to hopefully join us, and then if she can't manage it for whatever reason, because I know that some people have had problems at their end with the signals. So are there any more sort of burning questions? I know that I'm seeing them sort of going
that a few have come up the same with fit testing and head scarves. Will, is there an issue with head scarves?
I don't see that there should be with headscarves, because really it's just about the mask fitting on the face. I mean, that's the only thing. What goes on around the head, as far as I'm concerned, doesn't make much of a difference. And a nurse that I work with in Hertfordshire has a headscarf and has passed the fit test, and there's no issues there at all, really. I think I was going to make a point about, I mean, obviously, Carl and I involved more with sort of implant surgery and things like that. And I guess for people who do more surgical work, there's sort of less of a learning curve to get over, I think, you know, because you're already used to donning surgical gear anyway. So if you're doing a surgical procedure, you're effectively going to be gowning up, but essentially you're just going to bolt on a higher level of mask, aren't you, really? You're probably also very proficient in removing these things properly as well. So, you know, I think for people who do more surgical work, you're probably going to find that learning curve a little bit easier.
Okay, thank you. There's another one that's come through interesting. Someone's done a webinar the other day on rubber dam, and they mentioned putting this over the nose now, which goes against everything that they've learned as a student. Have you got any advice?
Try not to suffocate your patient. Can get costly.
Quite.
I think I understand that, but we're not working in normal times, are we? And so I think that I just do it. You know, it's not normal times. I can understand it. Did I mention about the lacrimal gland, by the way, and the spray going in? So you've got these nice sealed masks that we're all worried about, but we're kind of forgetting there's another entrance. So unless we want to wear swimming goggles, so it's the weakest point. So the fact that we're looking at these respirators, and this is why I question a lot about what we're being advised and what we're being told that we must do. Probably irritates the heck out of Will sometimes. And so I ask lots and lots of questions, and that's not a bad thing. I hope it's a good thing.
Yeah.
But I take it that Fiona's not managed to join in.
No, I don't think so. Apologies to those of you that we haven't got round to with questions. We have been inundated prior to and during. If I can just ask the panel, please, just a quick fire couple of questions. Actual uniforms, questions coming through. We've got questions about whether it should be zip uniforms and not pull over your head. And also, when carrying out AGPs, is it recommended to wear disposable gowns or washable? And will they need to be changed for each patient?
What's everybody going to do in their own situation?
We haven't changed our uniform to zip up. We just sort of pull it off over the top of the head, and the only thing we are making sure we do is either bring it to work in a washable bag or a disposable carrier bag.
Okay, thank you, Shelley. Thank you.
What I'm going to do, I mean, I can see that we're running out of time, and I can see that Will started yawning. So I think that and everybody's got homes to live in and not to go to, because you should already be in them, I would imagine. So I'm going to say thank you. I'm going to say a big thank you to Fiona Elwood on our behalf.
Thank you.
For sort of inviting us to do this webinar. She's been absolutely fantastic. It's been lovely having some conversations with her. And the team, I haven't really filled them in. I must apologise for that to everybody that's listening, and Fiona, to comment how complimentary you were on their participation, because I like to take all the glory. So I do thank yourself for allowing us to perform this presentation to everybody that was listening. We hope we've brought, in an attempt, what we were trying to do is explain the situation in a level way rather than a panic way, and probably reduce some of the fear that was sort of out there, but not get too technical and too bogged down with things. So it was basically just to make us all realize that hopefully we're gonna be all right. We're gonna get through this, and it's gonna be absolutely fine. We're all gonna manage. We're all gonna be okay. And what Fiona does is she's in charge of the Society for British Dental Nurses. We've been having lots and lots of conversations about that, and I would be really grateful if you'd have a look at their website. It's got a really good ethos on how they work, and they develop your potential. So it's something that I think you should all have a little look at, because I've had some very enlightening conversations, and I think they've got a very good sort of way of thinking, and hopefully they'll help you grow. And they were kind enough to ask Saul to get together again. So I don't know about you, but I've certainly enjoyed it again. It's been good talking to you. I know that
Yes.
I wouldn't have been doing this. I'd have been, I don't know, really researching aerosols again, getting that tattoo on my arm that we talked about earlier that I'm not allowed to repeat.
Incorrectly spelt.
For those of you that do want to watch this again, we will put to this on record, and we will give you a link as well to the society. We suggest that you check that out. You know, I've had some fantastic conversations with Fiona, and I think they've been superb. I think she's got a very good ethos towards the organisation. So for those of you that aren't members, I really do suggest you go and have a look at it. So we'll try and get that link up, certainly be on the replay. We also put this on YouTube as well. So you'll get a reminder within 24 hours, and I'll probably try and get one again within the next 12 hours. I'm really sorry, Kate, I'm taking your wind a little bit, but I'm really sorry that we haven't been able I've been watching the questions coming through and not paying attention to what the rest of them have been talking about. I've been ignoring them. So sorry, I haven't really. And I know that we're not able within the time that we have to answer some of those questions. So we will try as we go forward to answer those. I think they will become evident as we get through this. It is going to be okay. We are going to be all right. And, you know, we're in the healthcare profession to look after our patients, and that's the important thing to know. And it's going to be fine. We're just going to look like Darth Vader. Which is fine for me, because one of my sons
For a while.
And he's had enough of Darth Vader jokes to probably last him a lifetime, and now he's got to put up with more, because I'll be donning the mask and saying, Luke, I got all your presents every Christmas, the poor bugger.
Thank you, everybody. We hope you have a lovely evening, and have a great weekend.
Thanks all.
Thank you.
Cheers.
Bye.
Take care.
Bye.
Bye.
Bye.